Ma'am, please start. Kindly unmute
Good evening,
yourself.
all. Good evening, all. Wish you all a very happy and colorful Navratri. Navratriच्या खूप खूप शुभेच्छा. On behalf of MahaIP and MahaIP Women Committee, I welcome you all for this today's session on obesity and PCOD special. We always make an effort to take topics which are very relevant to general pediatricians. And this is one such topic, because this is very common that young teenage obese girl is sitting in front of general pediatrician and he is thinking in his mind कि अब मैं क्या करूं, भेजू गायनिक के पास, भेजू एंडोक्राइन के पास, भेजू मैं हैंडल करूं, क्या करूं. एंड इट इज नॉट वेरी इजी टू कन्विंस पेरेंट्स ऑल्सो. Otherwise normal looking happy adolescent sent to gynec, sent to endocrinology, and many times the specialist may not be even available with general pediatrician. So we have taken this topic, and I'm very thankful to Dr. Tushar, Dr. Ankita, and our own Dr. Renu Boralkar madam, who have consented to be special speakers today. And thanks to Dr. Sandhya Kondapalle, she has taken initiative to organize this program and she has coordinated it, everything. So to start this session, I first welcome Dr. Sanjay Pakmode, President MahaIP, to offer his welcome.
Thank you, Jam. Namaskar. Once again, welcome to the MahaIP platform. As Madam has said, Happy Navratri to all of you. And our women's wing is very instrumental in celebrating the so many days or months. So this month is also observed, seen as a PCOD or PCOS awareness month, September month. Yes. So from that point, it is also very relevant. And second thing, we are dealing with the obesity, which is a very common problem in nowadays in the pediatrics, especially after the COVID. We are dealing with so many children's coming to our OPDs, which were thin built, and now we are dealing with the management of the people who are coming with the overweight and the obese patients. And now in this topic, we are especially dealing with the girls. So obese girls, as Madam has said, having a such common problem because this obesity has a very good relation with the PCOS. So it's a PCOS, which is a very complex metabolic, hormonal, and reproductive problem. So all our three experts, one is the endocrinologist, then one is a common general pediatricians, and one is a gynecologist. They are going to tell us in detail about this particular association of obesity and how its management depends, because it is related to other things also, like this type 2 diabetes and other cosmetology problem like acne, hirsutism, and all those things. So it's very important issues, because at that particular age, everybody is well aware of his look. And so we as a general pediatrician must know how to deal with such type of patient, when to refer, where to refer, and how to, because ultimately the patient since beginning believes in us. So it's our duty, we should know this topic in general, and so we should do the good management of that particular adolescent girl who is coming to our OPD. So that's the idea, I think, behind this particular today's session. Let me welcome today on this platform, this today's speaker, Dr. Tushar Godbole sir, Dr. Renu Bolakal madam, and Sandhya Kodpalle madam. Thank you, Sandhya madam, for accepting our as a moderator, and especially Jaya madam, who is very women chairperson, which very instrumental in conducting this particular women's wings programs. And let me welcome Dr. Ankita, and who has also consented for this today's particular program, and all our secretary, Dynamic Secretary, Dr. Amol, and convener, Dr. Sanjay Deshmukh, and other Abbas known as a treasurer, and other MahaIP OBs and EBs, and other CIPBs who have joined for the particular this program, and Dr. Devendra Sarin, who is very regular in joining our program from Rajasthan. He was, when he was in US, he was still joining our program. So he is a very regular member who's attending from the other state to our program. So thank you, Sarin sir. So over to you, Jaya.
Yes, thank you so much, sir. It is because of your encouragement and support from Dr. Amol Pawar that we are conducting such sessions. So I invite Secretary Dr. Amol Pawar, sir, for his two words.
Thank you. Thank you, Jaya ma'am. First of all, good evening, everyone. Sanjay sir, Renu ma'am, our past chairperson, Tushar from my own place, Hushar, endocrinologist of India, and then Sandhya ma'am. Let me welcome different person from other faculty, Dr. Ankita Bobde ma'am. Thank you, ma'am, for accepting our invite. And thank you, Sandhya ma'am, for coordinating this very different but yet important webinar that is on adolescent issues and obesity. Just now we have been there in AdolsCon. It was conducted in Ahmedabad, and lot of issues related to adolescent healthcare they were discussed, and many of the new programs were initiated at that place. So let me tell you all that Jaya ma'am in the month of January only she told that we will be conducting many of the programs along with co-chairperson Amog ma'am, then Kashmiri and all the women committee member. Actually, this committee was formed in 2022. I think this may be the last Maharashtra AP Women Committee because from next year, whole of the constitution will have a change in Maharashtra IP and there will be women representative, but women committee will not be there in our constitution. So Sandhya ma'am was there as a Maha IP Women Committee member from Vidarbha. Renu ma'am was the first women committee chairperson of Maharashtra IIP, and she has done a lot of work on academics. She has conducted. She actually the other program of Maha IP Women Committee, which we are conducting now with the male coordinators. This Mahapika Punch Friday ka Punch Mahapike Sang. So that was actually a Tuesday text. We along with Renu ma'am, Dr. Gangulia, we coined this term Tuesday text, and that was the most hit program for 2 years. And then later on we changed the name for we conducted on Wednesday Wisdom, and now it has gone to Friday. So Renu ma'am has worked a lot for Maharashtra IAP, and she was a executive board member for consecutive 2 years, 23 and 24. So thank you, Jaya ma'am, for taking along with you all the women committee members. And this Thursday thrill, it was a again wonderful program involving two or three speakers on various subjects, and whole women committee they have helped you a lot. So thank you. At this end, I will end my speech, and I will request our Devendra Sarin sir and then Sanjay Deshmukh sir to speak for 2 to 3 minutes each. So first, Devendra Sarin sir. Let me tell you, Devendra Sarin sir is a Padma Shri nominee person. He is a teacher of teachers. Since last 45 years, he has been in teaching in Udaipur. I have personally went in 2023, I think, along with Dr. Vasant Khalatkar during his campaign. And Devendra Sarin sir was there to welcome us. And he has worked as an executive board member of National IIP for 2 years. So we'll ask him to speak first, and then our Sanjay Deshmukh sir, our convener. Devendra sir.
Thank you so much. Thank you, Amol bhai. Thank you so much, Renu madam. Thank you, Sanjay Pakmode sir. Thank you, Dr. Sanjay Deshmukh sir. And then Tushar sir, Ankita madam, Sandhya madam, then also others also, Shivalkar madam and others also. So really I'm so happy to join this. As Dr. Sanjay Pakmode said कि सर आप वहां से भी ज्वाइन करते थे, मैंने कहा अट्रैक्शन इतना अच्छा होता है, इतनी बढ़िया आपकी ये होती है कि जब भी मैं कभी मिस कर जाता हूं तो मुझे बहुत दुख होता है. आई एम रियली आई एंजॉय एंड आप लोगों का जो अफेक्शन, लव एंड अफेक्शन है एंड एकेडमिक्स है, दिस आई रियली लव एंड आई अप्रिशिएट दिस. आई होप इसी तरीके से जो विमेन विंग है उसकी एक्टिविटीज भी आगे होती रहेंगी एंड दिस विल शाइन लाइक द सन, हम लोग कहते हैं, हम यही चाहते हैं. एंड देयर इज ए वेरी गुड कोऑर्डिनेशन एंड कोऑपरेशन बिटवीन ऑल ऑफ यू. दिस आई हैव लर्न फ्रॉम यू सर. एंड हम भी ये कोशिश करते हैं हर जगह पे ऐसा ही कोऑर्डिनेशन और कोऑपरेशन होना चाहिए. You all have set an example. So my best wishes are always with you, sir. Always with you. Thank you so much for calling me. Thank you so much.
Sanjay sir.
Thank you,
Sanjay sir.
sir. Yeah. Now I invite Dr. Sanjay Deshmukh, convener, to say a few words.
So good evening. Already the stage is set by all the starbursts from Maha-IP Women Committee members, Dr. Jaya Shivakar Madam, Dr. Amog, and today we have the galaxy of speakers to listen the most important burning topics, the obesity. As you know, Government of India is also planning to concentrate on all these NCDs, non-communicable disease. And believe me, this will be we always tell iceberg phenomena. So apart from malnourishment, the obesity has the major burden for coming generations. Today only I just saw one clip from an Insta. One young student died of heart attack. The video circulating there. So it's a major concern. And today we have the dynamic Tushar Gorbole, Dr. Ankita Bobre, Dr. Jaya Shivakar ma'am, and Dr. Sandhya Kotpale to discuss this. So my best wishes, and I hope I will tell Amol.
Dr. Renu also.
Amol, this committee will, even if the constitution has the things, there are the ways to give chance to our dynamic women committee members. So you know better. And Sanjay,
You missed Renu ma'am's name.
Yeah. So this committee will be definitely continue under different names. So I wish you all the best. Thank you.
Yes, definitely we'll find a way to be active
Balance.
in the same way. And what I especially like that this women's committee is working in tune with all the gents members. I mean, it is not like a gender bias, but it is working together to complement each other. And we hope to find some way to continue in the same way. So now I invite Dr. Sandhya Kondapalle Madam. She is a moderator for today's session. She is zonal member of Maha-IP Women's Committee. She is pediatric endocrinologist from Sambhaji Nagar, and she is going to be the moderator and coordinator for today's session. So I invite Sandhya Madam to take the program forward. Sandhya Madam.
Please unmute, ma'am. Please unmute. Yes.
Thank you so much, Jaya Madam, for the kind introduction. A very good evening to all of you. सर्वात प्रथम नवरात्रीच्या तुम्हाला सगळ्यांना हार्दिक हार्दिक शुभेच्छा. At the outset, I will like to thank Dr. Sanjay Pakmode sir, who is President Maha-IP, Dr. Amol Pawar sir, who is Secretary Maha-IP, Dr. Sanjay Deshmukh sir, who is convener for this platform, and of course Dr. Jaya Shivalkar madam, who is the WC of Maha-IP Women Singh, and also for today's session, she is MOC also. So thanks to you all for giving us this opportunity to discuss on this very important topic related to the health of our adolescent girls. It's a very good coincidence actually that currently in Navratri days, we all are worshipping the goddess of strength, maybe goddess of prosperity, and all these adolescent girls, they are actually our Navadurgas. So we are discussing in this month of PCOS and the time of Navratri, we are discussing a very important issue related to our adolescent girls, and it is obesity and PCOD. What we are seeing that with the changing days, with the changing environment, with changing food habits, junk food, and of course, with our changing lifestyle, we are facing newer and newer challenges of the non-communicable diseases. And of course, one single specialty, it is not enough to deal with all these disorders. So we need a group of consultants, group of specialties to deal with these disorders. Of course, obesity in adolescent girls and PCOD is also one of these topics. And we need here general pediatrician, endocrinologist, gynecologist, nutritionist, then exercise experts, and sometimes psychologists also. So here on today's platform, we have a wonderful team of pediatric endocrinologist, Dr. Tushar Godbole from Nashik, then senior pediatrician, Dr. Renu Boralkar madam from Chhatrapati Sambhajinagar, and gynecologist from Chhatrapati Sambhajinagar, Dr. Ankita Bobde madam. And all these experts, I'm sure they are going to make this topic very interesting. To make it more interesting, we have made this topic case-based. So let's hope that you will all enjoy the today's discussion and it will prove useful for our day-to-day practice. So let me share the screen. Okay, is it visible?
Yes, yes.
Okay.
Ma'am, it is visible. It is
Yes.
visible. Kindly
Okay.
go ahead. Thank you.
Thank you. Thank you. So first of all, I will like to introduce our today's faculties. Dr. Renu Boralkar madam, she is gold medalist of MD Pediatric. She is currently working as senior pediatric consultant in Kamal Nayan Bajaj Hospital, Chhatrapati Sambhajinagar. She was Central IAP Executive Member in 2023 and 24, Organizing Joint Secretary of West Zone Pedicon in 2024. She was Chairperson of Women's Committee Maha IAP 2022, and she was President IAP Aurangabad in 2022. Her areas of interest are pediatric intensive care, infectious diseases, adolescent, type 1 diabetes. She is a PG teacher for DNB and CPS also. Let me tell you that Renu madam, she is the most active member of our women's wing from IAP Chhatrapati Sambhajinagar. So welcome, Dr. Renu. Then Dr. Tushar Godbole, no need to introduce Tushar actually. He is a renowned pediatric endocrinologist in Nashik. He is currently Director, Harmony Health Club, Nashik. He is Associate Professor at Dr. Vasantrao Pawar Medical College, Nashik. He is visiting consultant to our place also, Sambhajinagar. He has written book chapters in Ghai's textbook of pediatric, textbook of endocrinology, and PG textbook of pediatrics. On his name, he has 5 national and 5 international publications also. He is executive board member of ISPI. He was in 2025, 2015 and 2019. He is editor Maha IAP Bulletin in 2015 and 16. He is a achiever of Sarla Vaishnav Award for Best Research Paper. So let me introduce our third speaker. Welcome, Dr. Ankita. She is actually working with us in Manik Hospital. She is MBBS, DGO, FMMS. Her work experience, she has worked at Apollo Hospital, Chennai, Galaxy Care Laparoscopic Hospital, Pune, Government Medical College Hospital, Dr. Chhatrapati Sambhajinagar, and Endoworld Hospital Private Limited, Chhatrapati Sambhajinagar. Currently, she is working in Manik Hospital and Research Center as full-time consultant obstetrician and gynecologist. Her special interests are high-risk pregnancy, laparoscopy, office hysterectomy, and I will like to tell you, herself and me, we both are conducting PCOD clinic, especially for adolescent girls since last 1 year. So welcome all the speakers, and we will start our panel discussion. Our first case, she is a 14 years girl having excessive weight gain since last 3 to 4 years. Menarche 1 year back. Mother is concerned about her irregular cycles at 2 to 3 months intervals, and sometimes it comes at 15 days interval also. In past history, she is having no history of head injury, CNS infection, no any chronic illness, no long-term medication. In birth history, she was born full-term, normal delivery, cried immediately, birth weight was 2 kg, milestones were within normal limit. In diet history, she is very fond of junk food, bakery items, and very poor physical activity, and screen time is around 4 to 5 hours per day. Family history, mother and maternal aunt are overweight. On examination, the girl looks overweight with central obesity. Acanthosis are there on nape of neck and axilla. There are stretch marks present on both the flanks. Her BP is 120/70, which is okay for her age, around 50th centile. Her sex maturity rate is B4, P4, A3, and menarche started 1 year back. Systemic examination essentially normal. In anthropometry, her BMI is 26.1. 26.2 kg per meter square. Let us see her growth chart. So obviously she is sitting on a higher centiles, around 98th centile for weight. She is sitting on higher centiles for her mid-parental height also. And look at her BMI, it is already crossed 97th centile, or in these days what we call as 27th equivalent of adult equivalent. So she's by definition also she is obese. So first question I will like to ask Dr. Ankita, should we label this as PCOD, and how to differentiate between just menstrual irregularities at this age and PCOD, and how will you counsel the mother? So Dr. Ankita.
Thank you, Dr. Sandhya Konpalle ma'am, for and Maha IP Society for giving me this opportunity. So we can see in the case we can see that menarche is just 1 year back. So according to definition, during adolescence, from menarche up to 2 years, the menstrual irregularities will be there. So directly we cannot label this case as a PCOD. We have to wait for 2 years to get HPO-axis mature. And then after that, if these irregularities and all the symptoms are there, then we can start investigating this case. So persistence of all these irregularities like irregular menstrual cycles, hyperandrogenism, polycystic ovarian morphology, and insulin. These are the common physiology of adolescent patients. So after 2 years of persistence of these symptoms, we can label it as a PCOD. But in this case, it is only 1 year from the menarche. So we will not label this patient as a PCOD patient, or we will not start investigating this patient. We have to reassure mother and patient also, let things happen and settle, and then we will look forward for this case to avoid the overdiagnosis.
Yes. Okay, Ankita. This means it is the definition of PCOD we can apply after 2 years of menarche. This is the important point of this discussion. So how will you deal with the early menstrual irregularities? Because many a times it happens that she comes within first 1 year. Mother is concerned whether it is PCOD, and mother is of course concerned about the various irregularities of menstrual cycle. So how will you deal with, how we should deal with this?
So basically, we have to counsel mother that the first few cycles will be anovulatory because HPO-axis is not mature till date. So we have to counsel mother that please we have to do for wait and watch these things. So that and if anything like if heavy menses or anything irregular cycles are there, we can treat her symptomatically also. And main thing is we have to tell them that healthy lifestyle modification and anything like dietary changes, exercise for weight gain. But we should not start with we should avoid OC pills within first 3 to 4 years or after menarche.
Thank you, Ankita. So, Dr. Renu, then Dr. Ankita is saying, yes, this is not PCOD, and we should not be in a hurry to diagnose PCOD in first 2 years of menarche. So finally, what should be the diagnosis, and how should we prevent it, and how should we pick up the red flags? What are the risk factors?
Yeah, so the diagnosis most likely to be exogenous obesity, or we can say a primary obesity, or we can say it is a nutritional obesity, as the history is saying it all, and all the whatever you have said, the parameters that she's crossing the 27th adult equivalent. So she is obese. Obesity labeled as this, and yes, it was preventable But we can see that she was loving so much junk food, bakery foods, and so many 4 to 5 hours of screen time was preventable, and also no physical activity. All these are the factors which are risks for like, having a obesity. So we know that the obesity has a risk now. It has to the higher epidemic is there in all over the world, and we have so many children after COVID. So we are plotting it on the growth charts and the BMI, and we are seeing that the many of them are having the overweight and obese. So the risk factors are that the obese parents, and then we know that if one parent is obese, the 40% chance of child getting obesity is there. And if both are obese, then it is 80% chance. So the parents' obesity is first and most important part of it. Birth weight less than 2.5 kg or more than 3.5 kg is there. There are prenatal factors like maternal nutrition or gestational diabetes mellitus, excessive weight gain during pregnancies, also IUGR. Then lifestyle factors in children like physical inactivity, as we have seen in this girl, then improper sleep hygiene and excessive screen time. There are also the dietary factors where the eating behaviors may be abnormal. Also, overfeeding there can be there during the complementary feeding or below 2 years, and formula feeds might be given. Excessive junks, as we have seen, are seeing today's children going towards the commercial advertisements, and they are eating right and left the just because of the online things which are available like Zomato, etc. And so the environmental also, there are factors like easy access to the junks like supermarket stores, and also paucity of the playground. These are all the risk factors. Then the red flags which are seen is that the change in the BMI centile which occurs in three groups, especially infancy, also during the 5 to 6 years of age, and during puberty. There is rapid weight gain. There might be hyperphagia in certain below 5 years of age. Skin changes like acanthosis nigricans. Then the red flags can be that child may be difficulty in breathing, or he may have a sleep apnea, or getting easily tired during physical activity, and joint pains with deformity in legs. And sometimes there can be endocrine things also, which may be causing the red flags. And the preventive measures for the obesity, first and most is the, as we have seen, prevention of maternal obesity has to be done. And what is there is that exclusive breastfeeding for the first 6 months and has to be continued along with the complementary feeding. The breastfeeding should be continued till 2 years. The complementary food should include cereals, fruits, and vegetables, and it has to be a balanced diet. Provide diverse and healthy food. We have to avoid the salt in first year add-on, and also sugars till the second year of life as an add-on in the meals of the children. Parenting, as we have seen that if it is permissive, children will have their behavioral problems, eating problems. So it has to be authoritative parenting, that is most important. As we have seen, BMI monitor has to be done during infancy. There are various things, charts available by WHO as 5 to 6 years. And for pubertal, there is IAP 2015 WHO BMI IAP 215, that is 2015 BMI charts are available. The most important thing nowadays, no screen during meals, and you have to promote a fixed meal time together with the family, increase the physical activity, limit the screen time, avoid snacking during any TV or whatever mobile watching. So no to that. And also the most important thing is that it has to be a combined effort at the level of the family, school, society, and the government and the stakeholders.
Yes, thank you, Renu. That's a very concise answer regarding the adolescent obesity. And now coming to Dr. Tushar, will you advise only lifestyle modification in this obese girl with some menstrual irregularities since last 1 year, or will you consider early metabolic screening? Is it necessary at this stage? And if necessary, what will be the investigation needed?
Correct. So, first of all, thank you, Dr. Sandhya, for including me in this panel, and thank you, Maha IP, and especially Women's Wing. So, if we look at the history, it's not just an overweight girl with little bit of acanthosis. This is a girl who has been having multiple problems. She was born small, so she was born SGA, 2 kilograms. That is one risk factor. Second risk factor is although we are wary of labeling her as PCOS, she could definitely be an evolving PCOS, because this is the girl who is going to come to us after maybe 1 year, and we will at that time label her PCOS. Secondly, she has strong family history of obesity from maternal side as well as the maternal aunts, and her BMI is quite high. So I think there will be certain clinical things that I would be monitoring, such as the waist circumference, the waist to hip ratio, of course, blood pressure. Often in pediatric OPDs, in a busy OPD with monsoon season, we often fail to check the blood pressure, but the pediatrician should take out time to document blood pressure, and we'll all be surprised that almost 25% of the obese adolescents that come to us indeed are hypertensive. So I agree with you that basic screening for waist circumference and blood pressure, and we should have those centiles ready in the OPDs to interpret. 120 and 70 apparently seems normal, but we have to see the height and see the centiles. Coming to investigations, probably pre-COVID times, I would have said that let us just improve the lifestyle for this girl. Let us revisit the issue after a couple of months. But Dr. Sandhya will also agree that we have been seeing so much of type 2 diabetes happening right at 12 and 13 and 14 years, not just in obese, but overweight girls with acanthosis. So my answer will be just do basic investigations for this girl who is obese with a bad lifestyle and history of obesity and PCOS in the family. Plus, she has some clinical markers in the examination. So, for all children above 10 years who are obese, lipid profile is a must. A fasting sugar gives you the diagnosis towards metabolic syndrome, which is a precursor for future cardiovascular risks. So, fasting sugar, lipid profile. Then I would be doing an SGPT, if not the entire liver function test, because it's cost effective, for transaminitis, which is a part of your non-alcoholic or the metabolic liver disease. There are, a lot of controversies about fasting insulin. Personally, I am not in favor, because most of the clinical guidelines for pediatric obesity discourage doing fasting insulin. But if somebody has done it and it has come elevated, it helps us in telling the patient that look, the insulin is high. But although in my personal opinion and as per the guidelines also, I'll not be doing fasting insulin. I think sleep studies for selective cases where there is daytime somnolence, snoring episodes, sudden deterioration in the school performance, then as a part of obesity workup, I'll be doing sleep studies. Uric acid is often elevated as a part of obesity. USG not for PCOS per se, but definitely for fatty liver. Grade 1 and 2 fatty liver is easily visible. So I'll agree with fasting sugar. OGTT, of course, I forgot to mention. It's very important. If your patient is a local patient that can wait in your OPD for a couple of hours, get an OGTT done. But if the patient comes from remote places, just a fasting sugar or even a random sugar is also fine. And then I would add HbA1c, which is rather than spending money on fasting insulin, I'll rather get an HbA1c done.
Thanks, Tushar, for the valuable inputs. So now here is a second case. She's 17 years girl, presented with irregular cycles. Menarche was at 12 years of age, and she is having irregular cycles since last 3 years. She's having menorrhagia along with prolonged cycles. The girl is also quite anxious because of acne and facial hair, which has appeared since last 1 year. In birth history, she is born full term by LSES. Birth weight was 3.6 kg. No NICU stay. Milestones quite okay. In diet history, according to her mother, she has recently left eating junk food and bakery items and chips, which is a very, very common diet history in any obese or otherwise. In family history, her maternal aunt was having irregular periods and she is having infertility. On examinations, she obviously looks obese. hyperpigmented patches are there on her face. There are cystic acne over her face and back also. Coarse facial hairs on both the lateral sides of her face. Upper lip hair is there, acanthos is there. She is having obvious central obesity. Her BP is 120/80 at the age of 17. So look at the child. She is having upper lip hair on her forehead. There are obvious acne on her both the sides of chin. If you see, there are obvious hyperpigmented patches we can see. On cheek also there are acne. Some of them are cystic acne, and on her lateral side we can see obvious hirsutism or facial hair are there. Her growth chart, if we see, she's sitting on a higher centiles for weight. Her BMI is about 27th equivalent of adult equivalent. So we did her investigations. Of course, it was necessary by the history. Her fasting insulin was high, 31.1. Her FSH was 6.47 and LH was 15.4. So her ratio of LH to FSH was more than 2. Total testosterone we did, it was 79.8 nanograms per DL. Prolactin was slightly higher than the normal range. Her TFT was normal and her anti-mullerian hormone was above the normal range, just above the normal range. So we did her sonography and it was showing right ovary, which was having 12.2 of volume. Left ovary was 14.7 cc. Both the ovaries were appearing bulky and echogenic, and there were peripherally arranged multiple follicles. So according to radiologist also, these findings were consistent with the PCOD morphology. Our first question about this case is to Dr. Ankita. What is the diagnosis? Should we label this case as PCOD, and what criteria should we apply to define PCOD or to diagnose PCOD in this girl, and what are the long-term fertility outcomes in case of PCOD?
So we can see from the history examination and all the investigation part that this case fulfills the criteria of PCOD. So basically, for to diagnose PCOD, we have three schools of thoughts. So according to NIH and CDH criteria, both the features are required, like oligo or anovulation and hyperandrogenism. It may be clinical or biochemical. And according to Rotterdam criteria, diagnosis requires two of the three following features, like first is oligo or anovulation, second is hyperandrogenism, which may be clinical or biochemical, and third is polycystic ovaries on ultrasound. So nowadays,
yes, which guidelines usually we follow all over the world?
Usually, we follow Rotterdam criteria. We need 2 out of 3 features, which I told before. And for polycystic ovaries, I just want to tell you a few things. That basically on sonography, pelvic sonography, we are seeing how many antral follicles are there. AFC, we count AFC, antral follicular count. So what is antral follicles? They are 2 to 9 mm in size usually, and this is like and it has to be more than 12 follicles, has to be more than. But nowadays the criteria is changed by the society, like AEPCOS society. They have told that there should be 25 or more follicles of 2 to 9 mm size.
And can we relate AMH to this number of follicles?
That's what I want to tell you few things. So nowadays AMH level, serum AMH level is getting importance in diagnosis PCOS. So what is AMH? First, the AMH is predominantly synthesized by the small antral follicles and pre-antral follicles, ranging from 2 to 9 mm size. So serum AH level is more specific and sensitive for the diagnosis of PCOS, like polycystic ovaries, because AMH is mainly secreted by the small antral follicles and pre-antral follicles. And on USG, we may miss few small follicles, or there may be observational changes from with person to person changes also. So if we measure serum AMH level, so we can get a definite good idea of the how many follicles are there, and if PCOD is there. So nowadays AMH is becoming important to diagnose the PCO, polycystic ovary. And one more thing is PCO, the serum AMH level, it doesn't depend on the menstrual day of the menstrual cycle also. It is independent of the day or specific timing of the menstrual period. So that is also important thing here.
One advantage that we can do at any time.
Anytime.
Okay. Yes, Tushar, please.
Sorry, but I have a little bit of difference of opinion here, because what Dr. Ankita is saying is absolutely correct for adult PCOS. But since the audience is pediatricians, let me make it very clear that adolescent PCOS and adult PCOS are different. When we are talking about adolescent PCOS, it is up to 8 years of gynecological age. So from the menarche, first 8 years we consider as adolescent PCOS. Now, in adolescent PCOS, we do not rely on the ultrasound features, because almost 30 to 40% of the adolescent girls will have PCOS morphology. So we'll inadvertently keep labeling many of the normal adolescents as PCOS. That's one. And secondly, AMH, we do not have normative values for Indian adolescent girls on AMH. So if somebody has done AMH and it is elevated, of course, it helps me. But it is more to do with the fertility outcomes. And as Dr. Ankita correctly said, it has got its merits when dealing with adult PCOS. But in adolescents, I would say that ultrasound is not mandatory and AMH is also not mandatory.
Okay, thanks for the valuable inputs. So according to Tushar, how should then we diagnose clinical criteria like hyperandrogenism, maybe clinical or biochemical, oligo, anovulation? So these two criteria are enough to diagnose PCOD after 2 years of menarche. That's your opinion.
I agree. Yeah.
Okay, thank you so much. So next question to Dr. Ankita. What is the prognosis of fertility in these children? Because of course her mother will be interested to know what is the prognosis after marriage. What will happen? Will my child have a good fertility, or will she have any issues in that? Very important question by mother's side.
So definitely in PCOD, fertility is going to be affected. I just want to correct it that there will be 70 to 80% patients with PCOD, they will be having infertility in their later life, because we know that PCOD is the anovulatory state, and there will be poor quality ovum also. So basically for fertility thing, we need ovulation and with good quality of ovum. So both these things are affected in fertility. So definitely these patients may get infertility. They may experience infertility in their latter life. So basically from the starting, we have to emphasize on lifestyle modifications for the fertility outcome also. And this patient, they may need a few ovulation induction and assisted reproductive techniques for their fertility outcomes. So definitely we have to do lifestyle modifications from the start only. We have to assure patients.
And any advice we should give the mother, or maybe to the girl, that if she wants to keep her fertility prognosis better, what should be the practical advice should we give?
Practical advice we will give that she should get married early and complete her fertility this thing faster, so that the quality of home will not be that much affected till the age.
And of course, the number of ovums will be also. Okay. Thank you so much. Dr. Renu, what is the etiology of PCOD, and how will you counsel the mother? Is it genetically? Because obviously nowadays the parents ask, why in my child? Is it inheritable? Is it due to any genetic factors? So what will be?
It is a complicated thing where there is contribution, both it is inherited as well as there are non-heritable factors also. Most importantly, the hyperandrogenemia and the polycystic ovaries are independent dominant traits, as we have seen in the previous discussion. And nearly half of the sisters of the patient with the PCOS, they are having the elevated testosterone levels. 70% of the sisters have polycystic ovaries on the ultrasound. Then also PCOS, even though not related to maternal PCOS, they're associated with the paternal metabolic syndrome is also seen in certain studies. And gestational factors, like as we have seen, the high and the low birth weight babies, they are known to be associated in later on having PCOS. And central obesity, insulin resistance play a part in the dysregulation of the steroidogenesis. So PCOS usually manifesting at puberty when this intrinsic genetic traits interacts with the congenital or the environmental factors. So it is a complicated thing where both the things can go hand in hand.
Yes, thank you, Renu. So we can label it as epigenetic inheritance because
Yeah.
some inherent genetic factors are there, and
Right.
their expression depends upon the environmental factors like maybe weight gain or faulty lifestyle or poor physical activity and everything. So it is a complex thing. Both the factors are involved in the etiology. That's like we can convince the mother. Dr. Tushar, now very important question. Should we label directly as PCOD? Any DDs in this case, you should consider as an endocrinologist. And what are the treatment options? How should we go?
Correct.
Yes.
So as we just discussed that in adolescent PCOS, we need the clinical or biochemical hyperandrogenism and oligomenorrhea. So naturally, there will be many conditions that satisfy either of these criteria. So we need to rule out those comorbidities. So for oligomenorrhea, we should be ruling out hypothyroidism and hyperprolactinemia as two contributing factors. And for hyperandrogenism, either clinical or biochemical. So CAH is one such condition where these girls, those who come to us at birth with ambiguous genitalia are typically the classical ones. Those come in the labor room with lateral enlargement. But there is something called as a non-classical CAH or the milder variety of CAH. These girls come to us later on. So CAH is one condition that we need to diagnose based on 17-hydroxyprogesterone. There will be a lot of girls who are actually very much lean, very much conscious about their diet, and they are fasting all the time to maintain their so-called figure. So these are the cases where hypothalamic amenorrhea is also possible nowadays. So we should be ruling out that. Lastly, apart from CAH, there are certain varieties of Cushing's syndrome, especially when there is a mixed hormone secretion from the adrenals. You could get obesity with virilization, hypertension, etc. So 17-hydroxyprogesterone, thyroid profile, prolactin, and a thorough drug history to look for any ingestion of steroids or any virilizing drugs such as phenytoin. We have to dig into the history. So after we have ruled out these comorbidities, we can label them as adolescent PCOS.
Okay. Should we do DHEAS if we are suspecting this adrenal tumor or androgen secreting adrenal tumor?
Yeah, I think if the degree of virilization is extreme and if there is associated hypertension, then I think we should definitely do DHEAS.
Okay, thank you. And now the most important thing is how to deal with this. This is the whole battery of investigations we should do in case of PCOD to diagnose and to rule out the other differentials like Dr. Tushar said. So now the most important question, how to deal with these cases.
Sandhya ma'am, can I ask you to elaborate the LHFSH? It's a very interesting point that pediatricians can take home.
Yes. Should I go back or should I just tell you that the LH-FSH ratio is more than 2? Okay. FSH is somewhat around 6.2 and LH is 15.4. Yes.
Thank you, ma'am.
Yes.
So, You want to elaborate on the non-pharmacological approaches,
Yes.
madam?
So how means this is a very, very practical question that the girl is been diagnosed as PCOD. Mother is sitting in front of us, and now how to start? Should we directly start on pharmacological management, or should we wait for some other lifestyle modification? And what will be the criteria to tell her that no, you can wait, you can do these things, and then we will go ahead like that? A very, very practical thing. How should we deal with this?
So I agree that as a part of obesity management as well, and the PCOS management, first approach, especially in the first case that we discussed, should be more of lifestyle modification, which includes around 5 to 7% of weight loss if the girl is already obese, and if the girl is overweight in growing age, we tell them about weight maintenance. So obesity reduction, the fat content reduction, will help improving the insulin resistance, which thereby will indirectly help us in dealing with the hyperandrogenism, reduce the LH levels, and also a large amount of patients with simple lifestyle modification also, we have seen that their cycles become regular. So lifestyle modification definitely for initial 3 to 6 months. If the symptoms of PCOS are not especially if they are evolving PCOS, we would focus more on lifestyle management. But if the girl comes to me with frank menstrual irregularities, amenorrhea for more than 3 months, or if the degree of hirsutism or the virilization is very, very severe, then in addition to lifestyle management, we will be treating them with oral medicines.
Yes. Okay. Okay. Thank you, Tushar. So this is the schematic presentation, how the various drugs will act and what is the mechanism of drugs. So now, most important question to Dr. Ankita, how will you decide about the choice of OC pills? Because OC pills, it is the area of gynecologist. Of course, because they are prescribed by them in various indications, not only in PCOD, but for various indications. So, Dr. Ankita, can you guide us? Now we have decided that lifestyle modification now has got no change in her condition. As like Dr. Tushar said, now this condition is so severe. There is hirsutism, there is amenorrhea, the child is obese with acanthosis, everything is there, and the investigations are clearly mentioning that it is PCOD. So now we want to go ahead with the OC pills. So are there any criteria? How should we go with the OC pills? Which OC pills will be of choice in which conditions? Can you tell us?
So first, as Dr. Tushar said, that lifestyle modification is the first most thing to do in this PCOD. But side by side, we can give OC pills in few patients. But while deciding on OC pills, first always go and see for the endometrial thickness in pelvic USG. If it is excess, we can only treat with mini pills like progesterone only pills. If endometrial thickness is not that much high, if it is thin, then we can go with the combination pills like
So can you tell us the limit? What should be the endometrial thickness? How much you will say that it is okay or it is high?
Yeah, if usually the if endometrial thickness is like 4 to 5 like below 5 then we should add estrogen plus progesterone. Because what happens when we add if we give means when we add estrogen, then that endometrial thickness will increase, and then only progesterone receptors will be expressing, and then only progesterone will act, and the menstrual cycle will start. This is what normal mechanism is there. That's why first thing is always look for endometrial thickness in pelvic USG. And then the second part is choice of progesterone in the OC pills or combined pills, because estrogen will be the same, but there are different types of different generations of progesterones are available. So basically in OCP, while choosing progesterone, we need progesterone with anti-androgenic or less androgenic properties and less water retaining property. So because and we have a few progesterones like cyproterone acetate, then dinogest, then drospirenone, which has anti-androgenic property and less water retention property also. So patient will not have more weight gain with this, and the androgenic symptoms like acne, this hirsutism, they will also be lesser in this patient with using these progesterone components.
Yes. So if the child is having frank hirsutism, testosterone biochemically also testosterone is high, then definitely we will like to have a anti-androgen or less or no androgenic action like sapropterin. That's why you want to say. Okay, thank you so much to answer that important question. So now we will go ahead with our third case. She is 16 years girl, presented with irregular cycles since last 2 years. Menarche 4 years back. She has persistent acne and increased facial hair, not responding to dermatologist treatment. She is engaged in regular sports activities and lives a very regular healthy lifestyle. Look at her growth chart. It is all okay. Her weight centiles are also just below 50th centile. She's not obese or overweight. She's appropriate or maybe slightly lower weight. But she's having some symptoms of PCOD. So we have to go ahead with the tests. So insulin is borderline high, we can say. Again, here also FSH-LH ratio is reverse. FSH 6.3 and LH is 17.6. Her testosterone is also slightly high here. 60, usually we take it as cutoff. It is slightly higher than the cutoff. And her USG is also suggesting increased ovarian volume with bilaterally polycystic ovary. So by our all criteria we defined in our second case, she fits into PCOD. So how will you guide the mother in this case? She's worried that she's not agreeing with the diagnosis. So how will you convince her?
Yeah, right. So this is a case of lean PCOS or PCOD, which is not obese. So 70 to 80% of the adolescents, they are having obesity in PCOS, but this is a very few percentage of the girls who are lean have the PCOS. So they are having the similar metabolic and fertility related complications as like the obese PCOD. So any adolescent girl who is presenting with this irregular cycles, hyperandrogenism with clinical or biochemical parameters, and PCOD morphology on ultrasound, they need a evaluation and management as we have seen in the previous cases. And Sandhya, may I ask, is there is a more insulin resistance in lean PCOS as compared to obesity PCOS?
Yes, and that is the crux of this situation. Actually, that is the core fault in these children, in these girls. So Ankita will throw light on this. So
Right.
Dr. Ankita, her mother is absolutely not ready to accept the diagnosis in her thin child. How you are saying that she is having PCOD? So how will you explain her PCOD in her daughter? Of course. So what is this lean PCOD?
Yeah, so the lean PCOD, definitely mother will not be ready to accept this thing that my daughter is not obese. But still, there are few cases which are called as lean PCOD. So definitely in lean PCODs, the insulin resistance is more. And insulin resistance is because of it may be autoimmune and because of the defects in insulin receptors, and it can be inherited genetically also. So and there will be one more thing that the sex hormone binding globulins will be less in these cases, so the free testosterone will be more in these cases. So definitely we have to make we have to investigate these patients also for the PCOD and treat accordingly for this.
Okay, so you want to say like the classical PCOD where all the factors combine together like obesity, lifestyle derangements and inherent genetical factors. Here in this lean PCOD, more of insulin resistance is the core defect which leads to PCOD.
And
So
obesity thing is like obesity will add up on this everything.
yes, correct. So Dr. Tushar, how does management differ in lean versus classical PCOD? Is there any difference? Maybe in the treatment, maybe
So,
in the response.
yeah. So I would say, although they don't look obese from outside, their metabolic health is deranged, as correctly pointed out by both Dr. Ankita and Dr. Renu madam. So the principles would remain the same. So it's very difficult for the mother to accept that although she is lean, yet you are asking her to
I think Tushar's
follow a
connection is,
stringent.
yes, yes. So I think I
Yeah.
should, yes, yes. Mm,
So the principles would remain same.
yes,
The only thing that I can add to it is they are more insulin resistant,
yes.
and typically we will get history of early onset
Right.
type 2 diabetes in either of the parents or atya or
Mhm.
maushi, and acanthosis is pretty much marked in the lean. So addition of metformin will be of help in these
Yes,
girls.
thank you for the answer. And now today's last case, she's 15 years girl presented with appearance of coarse hair on her upper lip and chin over the last year. She has absolutely no any menstrual irregularities. Her BMI is also normal, below 50th centile, 20.1. Her hormone profile is absolutely normal. Ultrasound shows no polycystic morphology. Her both ovaries are normal, and her mother is worried about whether my girl is suffering from PCOD, and the girl itself is getting embarrassed due to increasing facial hair. There is no other significant history. Her systems are all okay. On examination, she was having average build, no central fat, BP was normal. Only thing she was having facial hair, which was increasing, and acne. Her SMR was B2, B2, P4, A3, and M plus. Sorry, it was B4. Systemic examination was within normal limits. So, Dr. Ankita, is there any concern for early signs of PCOD? Can we label this as early PCOD? Because there are some signs anything is going to evolve. How will you reassure the mother?
She can have, if there is anovulation, then she can definitely go in infertility. uh, Basically, I want to emphasize on this, that if there is hyperandrogenemia, then the quality of ovum basically is affected in this patient. And if cycles are normal, this ovum or a follicle is getting enlarging, but there is problem with rupture of follicles basically. Means we often find, while doing infertility treatments, we often find there is difficulty in rupture of the follicles. So in this scenario, definitely, for in infertility of point of view, we have to look for the quality of womb. It has to be good. So for that thing, we have the hyperandrogenic symptoms. We have to reduce her hyperandrogenemia, like testosterone levels and all.
And she can face all these things. Even if by definition she is not PCOD, she can have all these things along with fertility, infertility, like maybe PIH, preeclampsia. These incidences are more in these cases. Okay, thank you so much. So even if this is not PCOD, we have to be very, very aware about the future probable infertility, and we have to reduce the hyperandrogenism, maybe in way of medical management. So Dr. Tushar, what are the other causes of hirsutism other than PCOD? And when will you proceed further with endocrine evaluation in such cases?
So I'll be quick by saying that there are certain ethnicities where hirsutism is genetic, certain communities where you can just have a look at the mother, Atya, Maushi, and if they are having more body hair, then it could be just physiological or genetic.
Yes.
The severest forms of hirsutism, where we all know that there is something called as a modified Ferriman-Galloway score. So if modified FG score is very much on a higher side, more than 6 or 8, then the girl definitely warrants evaluation, and we will be ruling out the non-classical CAs, the adrenal tumors, Cushing's syndrome. One word of caution about prolactinemia: one must understand that prolactinemia, the primary prolactin secreting pathology, will not come to us with PCOS like picture. Whatever high prolactin we see in PCOS is secondary. So one should be very much cautious while interpreting the prolactin values. If the prolactin values are up to 2 to 3 times the upper range, then just forget it. It's not primary hyperprolactinemia. Hypothyroid, of course, it is. Some of them do have facial hair on the forehead, so we have to rule out these adrenal causes, prolactin and thyroid. And we have already discussed about the drug-induced hirsutism.
Yes, yes.
Trichosis than hirsutism when we are dealing with drug-induced hair growth.
Yes, yes. Thank you, Tushar. So this is the end of our discussion. I think all of us, we have tried to touch as many as possible discussion points regarding adolescent girl, obesity and PCOD. And all of us, all the speakers have tried to simplify the complex topic. So now our forum is open for the questions. So any questions we will take. We have, I think, maybe 15 to 20 minutes in our hand, 10 to 15 minutes. So any questions? Should I stop sharing?
I think so.
Yes. Yes.
There are questions in the chat box, Sandhya, I think so.
Yes, yes, yes.
Can we make a quick comment on the cosmetic treatments? Many of them do have
Yes, yes.
concerns about laser therapy and
Yes.
epilation. So can we all consider them
Yes.
safe in adolescents? I think they are pretty much safe.
Yes, yes. First question here, evaluation of hormone axis, that is LH-FSH, total testosterone, free androgen index, should be done on which day of cycle in case of a girl with irregular cycles? Ankita. Dr.
Unmute yourself.
Yes. Dr. Ankita, if not, Dr. Tushar, you also can answer this question, no problem.
Yeah.
So,
yes. Please.
Basically, for FSH LH, we need a day 2 or day 3 of menses of cycle value, definitely.
Yes.
It is cycle dependent.
Okay, okay. And the other question.
Morning time sampling is better.
Yes,
so
yes.
Day 3 of cycle,
Yes.
morning time.
Yes, yes. Diagnosis of PCOS, PCOD criteria, I think Tushar has answered it in chat box that I have explained already. Can you comment?
So adolescent PCOS, we have already discussed that it is just hyperandrogenism, either clinical or biochemical, coupled with oligomenorrhea. After ruling out 3 or 4 conditions, that is the adrenal pathology like CAH, hyperprolactinemia, and hypothyroidism. So if you have ruled out prolactin, thyroid, and adrenal, what remains is PCOS.
Okay, so yes. Then dose of metformin for lean PCOS and how long, and OC pills for how long? So I think dose of metformin, Tushar, you can say, and OC pills, we will divert this question to Ankita. So dose of metformin.
So metformin, it's a drug that reduces insulin resistance in a miraculous way. We yet don't know how it helps, but we know that it reduces insulin resistance and also has got a beneficial effect on the BMI as well as lipid profile. It increases the sensitivity of insulin and improves the ovulation also. The dose typically used is you can start with 250 grams for lean girls that are extremely, low weight, like a girl who is around 35-40 kilos. 250 milligrams is also a good dose to begin with. Many times these girls often have GI intolerance, so you could start with a lower dose, and depending on the response you could increase it to 500 milligrams twice a day. The maximum dose that is generally recommended or used in most of the clinical trials is 1.5 grams per day for 6 to 24 months. There is no safety and efficacy data of metformin beyond 24 months.
Yes, yes. And we can prescribe this drug about 10 years in any condition. PCOD, of course, it is not common up below 10 years, but we should remember the point that we should use it in about 10 years. And now OC pills for how long? Very, very good question. Ankita.
Basically, we give for 3 to 6 months, but simultaneously we have to go for lifestyle modification, all these things. If the weight reduction is simultaneously going, and then we will not need OC pills to continue. So basically this goes hand in hand, and we can use it for 3 to 6 months, 3 to 6 cycles.
Okay. For how much maximum period we can use these pills? Is
How
there any
much?
limit?
Yeah, no, actually there is no limit. Actually, for OC pills, what we say that below 35 years age, it is safe to use OC
Yes.
pills. Okay, but still we need to do few things like regular checkup of BP, then mammography for the these things, for to rule out the CA breast, these things, and lipid profiles for metabolic any derangement.
Yes, yes. So what Dr. Ankita's like to say that both things should go hand in hand, lifestyle modification as well as drugs. And if the child and the family follows the changed lifestyle, diet, and exercise schedules, which are being advised by nutritionists, doctors, and experts, the dose of or duration of the OC pills can be minimized. But it can be given for 1 to 1.5 years, and it is expected that till that time, changing lifestyle will just bring your or maybe metformin will bring the metabolism to utmost normal. So this is the thing which is expected. But if in very resistant cases, she likes to say that you can give prolonged OC pills, but with the caution that we should monitor for the side effects of OC pills. Yes. Then, what should be the diet advice for PCOD, especially regarding milk and other dietary and protein intake? Anyone of you can answer this question, of course.
Malvika madam, we can answer this question on evidence-based thing. There is no specific guideline or a specific mention of avoiding milk for PCOS in any of the international guidelines. But as a part of obesity management, of course, our grandparents have been feeding us with huge amounts of milk. 250 ml ते म्हशीचं दूध सकाळ संध्याकाळ प्यायल्यानंतर त्याला त्या मुलीला तिकडे 400-500 कॅलरीज सरप्लस होऊन जातात. सो कटिंग डाऊन ऑन मिल्क इनडायरेक्टली हेल्प्स इन रिड्युसिंग दी एक्स्ट्रा कॅलरिक बर्डन. We still don't know much of that hormone still remains as milk. Of course, raw unpasteurized milk will have some hormones, but once we pasteurize it, most of the hormone will be degraded. And on a personal level, I am of a strong opinion that humans do not need animal milk. So we need not ask our children to drink animal milk. But that's my personal opinion.
Yes. Okay. So one more question: use of soya protein or soybean oil is one of the cause in increasing incidence of PCOD. Any comment by speakers? No. No such evidence.
Soya, of course, soya protein has phytoestrogen, and PCOS is known to be hyperestrogenic state. So principally, yes, it should be avoided because it's a source of estrogen. But again, I have no evidence to support that.
Yes. And I think this is the last question. Any role of oral spironolactone or finasteride for the management of severe hyperandrogenism? Tushar. Yes.
Absolutely. So finasteride given at 2.5 to 5 milligram dose per day definitely helps in reducing the hair growth. After you have counseled for lifestyle and started on the lifestyle management, if the main concern is oligomenorrhea, I will be starting on OS first, and then go on to adding anti-testosterone drugs. If the major concern is not oligomenorrhea but the cosmetic part of it, I would rather start on finasteride first. If we are giving spironolactone, you cannot give it alone because adding aldactone or spironolactone in adolescent girls often causes intermittent spotting. So you have to give aldactone along with, spironolactone along with OC pills. But they are safe. You have to just monitor potassium levels, especially for spironolactone. Maintain hydration to prevent, since it's a diuretic. But both these drugs should be used in management of hirsutism in adolescent girls.
Yes, and of course, if it is very resistant, we have to go ahead with the laser treatment, of course.
Absolutely.
Yes, yes, yes. So I think we have already come to the end of our discussion. Any question? Any more question which is not there in the chat box?
How will you do the long-term counseling of the parents of these patients? Means
So
about
what
the
I tell
parents.
to my patients over last around 12 years that PCOS is a condition, it's a chronic disease with no cure. You can manage it, but there is no cure. There will be relapses if the girl is not able to follow a good lifestyle. And of course, there is a great amount of genetic component to it, which is nobody's fault. So although being optimistic that with good lifestyle management, some of the PCOS will be controlled, but often they require medicines, drug therapy, and many of them would require therapy until they are married and they are conceiving, and they go to Dr. Ankita for fertility management. So it's a long-term disease that continues till pregnancy. That's how I counsel.
Thank you.
Yes. So with this, sir, I think we have touched the important points of this discussion. So if there is no any further question, should we conclude the session?
Yes, ma'am.
Yes.
We can go.
So
Yeah, so as a senior pediatrician in this panel, I would like to say that as a common pediatrician, we came to know many aspects of PCOS, especially obese and lean, all the criterias, and so we should not be over-diagnosing it and labeling it as PCOS at the early post-menarche stage, as we have said that after 2 years. So the common pediatrician should at least know what we have come to know through this discussion, because rather than that, पहिल्या ह्याच्यात आपण म्हटलं की कुठे पाठवायचं, whether we should send to obstetrics or endocrinologist or XYZ. So that was a confusion. So I think as a common pediatrician, I got at the end of this the very important knowledge of many things. So thank you so much for this discussion, Sandhya. And to tell you that Sandhya's intro was not given in the start. She is a pediatric endocrinologist from Chhatrapati Sambhaji Nagar, and she works at Manik Hospital and Research Center. And she is very, very helpful to us pediatricians. At a one call, she gives the appointment to the patients, and also without showing the patients, we can also take her advice on telephonic consultation. So thank you so much, Sandhya, for moderating this today's session.
thanks, Renu, for the kind words. And we also enjoyed this session actually with the great speakers. It is always a very good idea to revise amongst ourselves also, and particularly such topics that include all the faculties. There are so many topics in the medicine or maybe in the pediatrics that don't owe to one single specialty. So we will like to have more and more such sessions in the future. So lastly, I will like to deliver the vote of thanks. Thanks to Dr. Sanjay Pakmode sir, Dr. Amol Pawar sir, for giving us this opportunity to present this important topic in form of panel discussion on this MahaAP Women's Wing platform. Thanks to Dr. Jaya Shivalkar madam. She is wonderful in supporting all these activities. Actually, she only has encouraged to do all these things and to choose the topic, and she was behind us to do the things in time. Maybe madam, sometimes we have troubled you. Sorry for that, and thank you so much for your all the way support. Thanks, Dr. Renu. We will always like to take the inputs, and she's so bold and so experienced. She has 30 years experience, and she's a renowned senior pediatrician. We always like to discuss some topics with her and always like to be with her. So thanks, Renu, for your very, very valuable inputs about particularly obesity. Thanks, Dr. Tushar, for giving us time and accepting our invitation to be a speaker. You were a very, very important speaker in this discussion, and thanks for adding the valuable inputs. Thanks,
pleasure.
Dr. Ankita. You were just important to complete all the topics, because as I said, we are never complete without you in the management of PCOD. We need you, and finally these PCOD topics end to the fertility, infertility issues. So I will like to say that it is a spectrum. It starts from adolescence and it ends to the conceptions. So right from pediatrician, in between maybe we as an endocrinologist, and finally people like you, particularly like Ankita, who is very, very interested in PCOD. She is a member of PCOD society and always deals with all the cases of not only PCOD, but maybe the primary amenorrhea, prolonged bleeding, very, very resistant cases of menstrual irregularities and infertility. So thank you so much, Ankita. Thanks to all the participants who are patient listeners and who have actively participated in the discussion. There were wonderful questions. What we missed, the audience has asked all the questions and I think completed the topic by themselves. Then all the senior doctors, senior pediatricians who are present for discussion, thank you so much. And finally, for the technical support, always being with us, Pallavi madam, thank you so much. So thanks for making this session so beautiful. Thank you so much. Thanks.
Dr. Tushar came on the very first day of MAHAIP, that is the 1st of Jan, with the journal journey.
I remember.
So he's always at our help. I mean, anytime we require his help, he's there, always there. Thank you.